I also sit in the healthcare practice group and the corporate and securities practice group. So as you might think, I do complex transactions on the technology side, especially as they relate to healthcare. And I was in-house at a software vendor for over a dozen years. So I've done multiple levels of transactions as they relate to contracting for technology and social media and mobile devices, and dealing with telemedicine from the contractual side. I also handle the regulatory aspects of telemedicine and mHealth routinely, representing both vendors of that technology and users and sponsors of mobile technology. Rebecca?
Good afternoon. My name is Rebecca Monson. I'm a member of both the Pepper Healthcare Services Practice Group as well as the Privacy, Security, and Data Protection Practice Group. In addition to healthcare regulatory compliance matters, my practice focuses on privacy and security requirements under HIPAA, HITECH, and various state privacy laws, and focuses on health information requirements and telemedicine as well. Dana?
Thank you, Rebecca. I work closely with both Rebecca and Sharon and have a very similar practice, although I tend to skew all over into operations a little bit more. So I handle regulatory and operational matters for healthcare providers and other entities in the healthcare space. That includes HIPAA compliance, breach notification, and the like. In California, we have similar, we have our own HIPAA, the CMIA, so it's also breach notification under that statute and other state laws, as well as fraud and abuse issues, corporate practice of medicine, medical staff governance, peer review credentialing, and as I said, operational issues for healthcare providers.
Great. So we're pleased to share with you today some of the basic principles of telemedicine. As I'm sure you all know, it's now official. As of last year, there are more mobile devices than people in the world. And it truly is becoming life on the phone and your health care on the phone, both from a physician perspective, healthcare provider, as well as the consumer patient. Patients are seeking help from doctors electronically, doing, virtual visits, sending off their, blood glucose numbers from a diabetic perspective and getting information back that will help chronic conditions. Doctors are looking at portals to be able to most effectively treat patients and help with patient engagement and physician engagement as well. So we have a lot to cover today, and our agenda is we'll start off with really what is telemedicine, treatment versus, educational or information telehealth. What are some of the privacy and security considerations? Obviously, HIPAA being primary, but there are others from a regulatory perspective that are very heavily involved, such as the FTC and the FCC. Telemedicine in action, where we'll actually go through some scenarios and analyze them from a regulatory perspective, and end with some best practices and practical takeaways. So with that, Dana, can you just kick it off with the basic principles of telemedicine? Thank you.
Yes, thanks, Sharon. So I'm going to give you a quick overview of what we mean when we talk about telemedicine and telehealth. There are a lot of different definitions for the concept of telemedicine. Essentially, it's the remote delivery of professional healthcare services and clinical information using telecommunications technology. The slide we've got up here shows the definition created by the Federation of State Medical Boards, which I think is very inclusive and a good definition. But it's important to keep in mind, depending on what regulatory scheme you're looking at, that the Centers for Medicare and Medicaid Services have their own definition. State laws may define telemedicine differently. The American Telemedicine Association has a different definition. So essentially, this is it. But it can come down to, if you're asking, is this telemedicine, you need to make sure you're looking at the right definition. Telehealth is distinct and broader than telemedicine. It does not always refer to the delivery of clinical medical services, but it can encompass them. It's telehealth is the use of telecommunications and information technology to provide access to a lot of different services, many of which are in clinical, but it also includes educational programs, public health programs, and some of the other things we've listed here. A lot of things may fall under the umbrella of telehealth. Telemedicine really is a subset thereof. If I can have the next slide, please. There are different ways that telemedicine can be delivered. We're going to speak about a couple of different ways today. Simultaneous telehealth delivery involves real-time interpretation or assessment. It can come up in telestroke, things of that nature. It's happening, the patient is there, the consultation is happening at the same time, whereas non-simultaneous involves after the fact or delayed interpretation or assessment of patient data. So it could include teleradiology, where the slides or the films are sent digitally and then a report is returned, but it may not be while it may or may not be while the patient is actually waiting for some type of diagnosis. State laws often specify in their definition of telemedicine which one they're talking about, so that's also something to pay attention to. And then there are some things that are generally not considered telemedicine, informal consultation between practitioners and things of that nature. While they're using technology, as we said, that they might fall under telehealth, but they're not within the definition of telemedicine. And I just point out that it's important to keep in mind that these are tools in the practice. It's not a distinct service. Really, telemedicine is a delivery mode for physicians who are providing clinical care. Next slide, please. Some of the players in telemedicine, obviously, if you're practicing medicine, you need a patient. There are two different types of provider that are distinguished between whether the provider is on-site or whether the provider is remote. Sometimes the on-site provider is called the telepresenter or the originating site presenter, whereas the remote provider is the distant site provider. Either can be the patient's treating physician. They could be in their treating physician's office getting a consultation, or there could be a specialist reviewing their information, or they could be with an allied health professional or some non-physician, or even on their own computer, communicating with their personal physician by telemedicine. So when we're talking about the different scenarios, it's one of the things we think about is who is the distant site and who is on-site, and what are their responsibilities because of where they are. Next slide. Some of the other participants in telemedicine is the technology vendor. We've got device manufacturers. We've got software and application developers. And those people sometimes are creating their devices, their products, they're selling it, and then they're out of the picture altogether. But sometimes they're intimately involved in the actual process of telemedicine being provided. And so that's also something that you look at when you're considering the requirements under HIPAA and who's obligated to comply with what. There are also the telecom carrier, the internet provider, and we'll talk a bit about that in a little bit. And then the payor, which can be Medicare, Medicaid, private payer. It also can just be the patient. So there's usually someone paying for the services, which may or may not be a health plan. And with that, I'm going to turn it over to Rebecca to look at the HIPAA, basics of HIPAA.
Thank you, Dana. Thank you, Dana. Okay, so now we're going to take a brief review over some of the key concepts under HIPAA. This is not going to be a comprehensive review of all the HIPAA privacy and security requirements, but really just to focus the discussion today on certain key terms and key concepts. So the first slide here, you'll see reference points to the different regulations. We've had now 15-plus years of regulations issued implementing HIPAA and the HITECH Act, particularly including the privacy requirements and the security requirements. I wanted to just briefly note the enforcement role here, both under civil and criminal penalties can be imposed for failure to comply, and now with various breach situations, and both the Federal Department of Health and Human Services through the Office of Civil Rights, as well as the Department of Justice with criminal penalties, can get involved in enforcement And most recently with HITECH, we have the role of the state's attorney generals who have the ability to bring civil actions on behalf of state residents for HIPAA violations. So with that, I wanted to turn first to several key terms. When we're talking about HIPAA privacy and security, the term protected health information becomes paramount. Protected health information does not include necessarily all health information out there, but really data that identifies a specific person, describes his or her demographics, medical status and history, and payment for care. And within that, we have EPHI, electronic protected health information that is maintained or transmitted in electronic form. And this is the information specifically which is regulated by HIPAA. What is also critical to understand is what is not PHI, and there is the exception for what is called de-identified information, information that does not identify the individual and which there's no basis to believe that the information could be used to re-identify that individual. There are two safe harbors available under the privacy rule to achieve de-identified status, so to speak. And additionally, there has been guidance issued by department on those methods and additional information which can be very informative if you are trying to take data that is PHI and convert it into de-identified information. So that is a little bit about the information itself. Who does HIPAA actually govern? Who is responsible under HIPAA? There's a defined category of covered entities, which include healthcare providers conducting electronic transactions. These are your institutional providers, as well as certain other non-institutional providers. A second bucket are health plans, and a third are the healthcare clearinghouses. Again, we often receive questions from clients about a HIPAA question, and one of the baseline things to consider is there a covered entity in the arrangement, or are we actually talking about health information that falls outside of having a covered entity involved and which may fall outside of HIPAA. As we'll discuss later on in a few moments, other laws may well apply, but whether or not HIPAA applies is impacted by the parties involved in handling the information. In addition to covered entities, there are business associates. This is a defined term under the rules. I've included a summary definition on the top, but a key aspect of whether or not an organization or party is a business associate is whether or not they are creating, receiving, maintaining, or transmitting PHI either on behalf of a covered entity or, as we'll talk in a moment, on behalf of another business associate. Some examples, include various consulting organizations, legal, accounting, administrative, and so forth, but it's the handling of PHI or creation of PHI which is critical. A brief comment on data transmission providers. Certain data transmission providers are considered business associates. In analyzing whether or not a data transmission provider falls under a definition of business associate, a key aspect of that analysis is whether they routinely access the PHI versus serving as what is called a mere conduit. An analogy for the mere conduit would be the Postal Service, your Federal Express or digital couriers, for example, would most likely not be business associates and would be considered mere conduits. There is some discussion in the preambles to the final omnibus rule that delves into this point further, which may be of interest to some of our listeners. As I mentioned, business associates also include subcontractor business associates, and this becomes very important, as I'll move to the next slide to give you an illustration, is the down the stream, down the chain concept of several layers removed from the covered entity may be a subcontractor. But if that party is creating and receiving or maintaining PHI on behalf of an upstream business associate, they themselves are considered a business associate and are required to comply with the privacy and security requirements of a business associate under HIPAA. This is manifested through, or I should say the agreement to comply among the parties becomes manifested through the business associate agreement, the contract that outlines the various obligations. There are elements addressed under the regulations that must be included in the BAA. It's important to note that whether or not the BAA is actually executed is not determinative of whether or not there is a business associate relationship. If the information is being handled in such a fashion that the downstream party, so to speak, is a business associate and they fail to execute a BAA, does not relieve the business associate of their obligations to comply with HIPAA. I want to, as I mentioned on the BAAs, there are elements that the privacy rule and security rule require to be included in the agreement. These are listed here on your slide, and in the interest of time, I'm not going to read through them. In addition to these provisions, however, there are others that are negotiable provisions that the parties can negotiate, and these include, of course, indemnification, how breach situations will be handled, possibly requiring cyber insurance, timing issues, and so on. I briefly want to touch on a few key concepts under the privacy and security rules that particularly pertain to today's discussion. The first area are individual rights, and that HIPAA provides individuals with rights both to access their information, to request amendments, to request certain protections, and to receive a notice of privacy practices. And these are all individual rights that need to be considered when developing a telemedicine arrangement, which parties are going to be handling some of the logistics of these, who is going to be obtaining the notice of privacy practices, how will access requests be handled. These are several examples of where individual rights need to be considered in a telemedicine arrangement. Security and all of the requirements under the security rule, both security of storage, maintenance, and transmission of the data. These are all very important areas, the safeguards that need to be taken, both the administrative safeguards as well as the physical safeguards where you may have a remote location or a distant site and the site where the individual patient may be located. How are those going to be secured? Of note, under the administrative safeguards, of course, is the risk assessment and the security management process. And the covered entity will have a vested interest in examining the different layers of the telemedicine arrangement for security, but a business associate as well has to comply and have a risk assessment and the management process. So how these fit together can become something that needs to be examined and discussed among the parties in setting up an arrangement. And finally, we can't have a HIPAA presentation without touching on breach notification and, a breach situation where there's a, acquisition, access, use, disclosure of PHI in a way that's not permitted and compromises the security of PHI. These situations may come up, of course, and then how, how the analysis will be conducted to determine whether a notice needs to be submitted and sent to patients, who will handle that, and all of the aspects of breach are things that need to be considered by the parties when setting up their arrangement.
Hey, Rebecca, thank you. Before we move on, I did want to give my first CLE word for folks that are interested in CLE. If you came a little late, what I'm going to do is give 4 code words that you need to write down, and then I'll give you a form when we're done today. So the first CLE word is going to be data. That's data, D-A-T-A, and I'll come back on in about 10 minutes with the second one. Thanks.
Okay, well, and now we were going to shift into beyond HIPAA to discuss some other privacy and security considerations. And Sharon, I'll turn it back over to you.
There, Sharon.
I think there's a slide before this on other state law issues. Thank you. Okay. Thank you, Rebecca, for, as always, an excellent presentation on HIPAA. We also need to visit on state law and other federal regulatory bodies that are becoming increasingly active in this area in enforcement. From a HIPAA perspective, HIPAA is floor preemption, and as Dana and I sit in California, we are very aware that there are many HIPAAs, like in California, the CMIA, that have different requirements. And to the extent those requirements are stricter than federal HIPAA, they must be respected. So as an example, in California, breach notification would be 15 days as opposed to the 60 to the individual that is mandated by HIPAA HITECH. The states are becoming much more active in enforcement through their attorney generals on data breaches because there is a lack of federal legislation that is comprehensive on data breach. So, we'll look for more class actions and other individual actions enforcing HIPAA-like remedies in the state arena. Next slide. Telemedicine versus mobile health or, telehealth, Dana did a very, very good job in analyzing those. Generally, when you're looking at telemedicine, there's a treating doctor involved, and the patient is sending messages to his or her physician, and that treatment instructions are coming back. But there are other sorts of medical applications where patients or consumers are entering their own information. Fitbits, Apple Health Kits, all of those are entering, quasi-medical information. How many steps? How did you sleep last night? And those things are recognized by HIPAA and HHS as not really falling under the strict construction of HIPAA, but rather consumer-based information that are regulated by the Federal Trade Commission and the FDA, the Food and Drug Administration, and potentially, if you're dealing with the cell phone or texting, the Federal Communications Commission. So understanding initially, is it a HIPAA issue, and we'll get into that just in a minute here on the scenarios, is extremely important. And in fact, acting on behalf of, as Rebecca indicated, in order to have a business associate of a covered entity is an analysis that we must undertake initially as we're dealing with that HIPAA issue. The Federal Trade Commission, and we'll talk a little bit more about them, regulates consumers under Section 5 of the FTC Act and has been extremely active in the Internet of Things, regulating mobile medical applications. One of their first enforcement actions is Payments MD, where a free app that helped individual consumers manage their health care benefits was rejected by the FTC since the privacy policies didn't really provide effective transparency and consent in collecting that management data, both for benefits and for a patient health report. The FDA has issued several guidances in mobile health and cybersecurity, and as I mentioned, the FCC is very active in texting. Next slide, please. So what are the various regulatory constraints here, and how do they work together? Telemedicine in action, from CMS's perspective, which obviously is the biggest payer in this country from reimbursement, is on the top of their wish list. What CMS wants is to enable patients to get medically necessary information and care in a more timely manner and manage chronic disease conditions, as I gave the example, the diabetic with the mobile app. Provide some help to small and especially rural hospitals that don't have those specialists that are necessary for healthcare treatment today, and effectively have an alternative to patients for traditional service delivery. So, for example, telemedicine can be a great key in making sure virtually that the initial visit to a primary care physician is limited. If, as a mom or a dad, you need to go get, a record of your son's immunizations for school that just started, you don't have to go to the primary care physician. You can get that off of a web portal. You can download it. You could ask your physician a question about, hey, my son just tripped, and can he participate in baseball this year? You can do all those remotely. You don't have to travel far distances in remote areas to get that kind of medical device. So it's an alternative to treatment so that when you do travel, that physician has more time with you to effectively practice medicine and not do the administrative work. And that will improve satisfaction for patients and better outcomes. Next slide. So some of the trends in telemedicine are really advancing electronically the continuum of care between healthcare entities, and we'll see that in the scenarios. So having data from the first interaction, maybe that's an EMT, going into the traditional acute care setting, and then going into post-acute rehab, and then home care. All of those can be effectively done electronically through telemedicine. Partnerships between insurers and systems that are in the rural area. Agreements between various telemedicine entities for virtual visits, virtual rounding for doctors, so they don't necessarily have to, go through the hospital patient by patient. They can look at you and understand and get the medical records and provide much more immediate care. And rapid development of mobile technology and mobile medical applications. At last check, just on iTunes alone, there are 43,000 health applications that can be downloaded. We believe from a trending perspective that that will only grow over time. Next slide. So again, as we're looking through scenarios, and we have 3 that we would like to work with you on, the initial question that all of us will explore is really, is this HIPAA? Or is this consumer transaction initiated by the patient where it's not the hospital or healthcare provider with a business associate acting on behalf of? Business associate agreements, service agreements, it's a business associate agreement if it's HIPAA. If it's just not HIPAA, but it has very sensitive information, you still want to protect it with some form of agreement called a service agreement. Physical security becomes very important in the virtual environment because you have network connections that are subject to vulnerability and hacking. You want to make sure that the person on the mobile phone, is the right person from an authentication perspective. We need to have physical, administrative, and technical security throughout the life cycle of the data: collection, transmission, access, disclosure, storage, and ownership. State law must be considered because there will be elements, and not only, as I mentioned, on breach notification, but there are special provisions for workers' comp. There are other provisions for, gene therapy, HIV, AIDS. So you need to think about who owns the data and what special provisions are necessary for state law. We touched briefly on the big regulator in the consumer patient mobile area, the Federal Trade Commission, which used its Section 5 enforcement power over time to issue 150 actions under CAN-SPAM, 50 under security, and 40 under privacy. Those actions are relatively easy to bring by the FTC. because their mandate is to police the internet for false, misleading, unfair, and deceptive trade practices, which could really mean that you and your privacy policy say it's very secure, and then you have a data breach. So that could fall right into the FTC enforcement action. So what we'd like to do now is have an interactive session dealing with 3 different scenarios. And next slide, I'll start it off with the basic scenario and introduce it. And Dana, if you would, perhaps you could first comment on the sort of web mobile application environment. And this is what we have been talking about as sort of the generic, if you will, mobile medical application, telemedicine scenario. And it's very straightforward. A patient interacts with a healthcare provider over the internet, emails the doctor. They might have an iPad, they might have their iPhone or some other, mobile smartphone. And they transmit information in this treating environment to the physician, who then responds. It might be a question, as I indicated, about, my son in a soccer game fell, and then emails the physician about, hey, what should I be doing about this? Do I need to come in, or is it just, ice and Tylenol? And the physician answers that question. Or from a chronic condition perspective, it may be more complicated. The patient might take his or her own blood pressure, send that reading to the physician, and the physician will then monitor the medications for the patient. So, Dana, the first question is, tell us whether HIPAA might apply and how in this scenario.
Dana, are you there? I don't know if you're on mute. We can't hear you.
I apologize. I was on mute. As I was saying, when we're asking the question, does HIPAA apply, the first question we really want to know is there a covered entity? Because that is the group of people who are primarily regulated under the statute and the privacy rules. Here we have a patient, we have a telecom provider, we've got the website or a mobile app, which could have a developer who's involved in this relationship, and then we have the physician. So starting with the physician, she likely would be classified as a covered entity under HIPAA. We need to ask, is she a healthcare provider that engages in certain covered transactions? So we know that she's a healthcare provider, and the question is, does she engage in these covered transactions? Generally, those transactions relate to whether a provider is participating with an insurance program, whether they're getting reimbursement or providing encounter data. These are the types of covered transactions that make a healthcare provider also be a covered entity. So if this physician is in a cash-only business, then potentially she's not a covered entity. However, and if she has a cash-only business on the web, but she has a practice separate from her website presence, and in that case, in her practice, she's using or has insurance contracts, then she's going to be a covered entity in her practice, and it's going to carry over to her web presence. So that being the first question, this is generally, when you're talking about a physician, an easy answer, yes, they're a covered entity. Very few are cash only. And going forward in these scenarios, we will assume that all of the providers are covered entities.
So Dana, what about this telecom provider in the middle here? Mm-hmm. Can you talk a little about that from a HIPAA perspective?
Yeah, that's what Rebecca was referring to with regard to if the exception for providers that are mere conduits and are providing services that involve PHI, because data is being transferred through their systems, but because it's intermittent, it's not persistent, the data is not staying on their system, it's just moving through, they would not be considered a covered entity for sure, or a business associate in this scenario or any other. If, on the other hand, the telecom provider was providing some sort of storage services and had some access to the data for the services they were providing, then they would be a business associate. But for the purposes of this scenario, they are not. And then lastly, we have the website and or mobile application. And the question there, again, is similar to the telecom provider. you have to drill down as to whether or not the developer or the owner of the website is providing services that require the use of PHI. If they are, if they're storing all of this, if it's an, they've got their own EMR in the background and they're storing the data, then they likely would be a business associate. If, on the other hand, this is some sort of a software program that they have created and it's a sort of off-the-shelf, it's downloaded and then the developer is out of it and out of the picture altogether and is not involved in ongoing services, then they would not be a business associate.
And this is, I'm sorry, Sharon, I'm running a little late.
Go ahead, Ryan.
Running a little late on my code words. My second code word I wanted to give folks for CLE was safety. That's safety, so the first word is data, and the second word is safety. Thanks, sorry, guys.
Let's move on in the interest of time to the second scenario. Dana? Okay.
So as for the second scenario, we have a patient who is admitted to a hospital emergency department. We'll assume that they came in on their own, not through an ambulance or an EMT. And the provider at the hospital, at the emergency department, determines that they need some sort of a diagnostic test, maybe an MRI. And so we will assume that this is happening at the wee hours of the night, 2 o'clock in the morning, and rather than have a radiologist come in to read the study that has been ordered and that's needed right away, we've got a teleradiology physician in a different time zone who is awake and ready to read that film. We've got here, again, that's got to be transmitted over the internet, and so we've indicated here that we have a software vendor that's assisting, software or a vendor assisting with this process of transmitting the data, and it could be that the data, again, is just being transferred without being stored by the software, and that we've got the dotted line represents that, versus, again, an EMR or a portal where the data is actually stored on a server provided by the vendor, and that would be the solid lines represent that. So, Rebecca, my question to you would be, how does HIPAA apply to this scenario as far as who the players are?
So here we have what would pretty clearly be protected health information flowing all the way through from the information that's put through the platform to the radiologist, both the images and perhaps some medical record information that accompanies that, and then the report back. So through the whole loop we have PHI. And I don't think there would be much argument that both the hospital emergency department and the teleradiology, the radiologist are themselves covered entities in this relationship, as well as any technicians in the emergency department and other personnel involved in the procedure. With respect to whether there are any business associates here, as Dana indicated, the role of the software vendor may or may not be a business associate if it's providing services ongoing, supporting the platforms that are used for the exchange of the scans and the reads back. You might have a business associate, and oftentimes the vendors may provide support services that require access to the records or to get onto the system, so to speak, to help out when there are problems. So if in that situation, there may need to be a business associate agreement with the vendor. Most likely would be directly with the vendor and the hospital, but it's conceivable that the arrangement would be structured that the teleradiology group is providing the overall arrangement and may bring the vendor to the process.
And Rebecca, would there be a business associate agreement between the hospital and the teleradiology physician?
Yeah, that would be unlikely. As they're both covered entities, what would be probably more appropriate would be for the overall services agreement that's governing the teleradiology services would have built into it protections for the data, agreements by the parties as to how the information will be handled, compliant with HIPAA and the applicable state laws, and in general governing the privacy, security, confidentiality of any protected health information or patient information generally.
Would that document also assign the responsibility for compliance with HIPAA with regard to patient rights and notice of privacy practices and things of that nature?
Yeah, I would think so. That would be the most appropriate place to address some of what I would characterize as logistics of who is going to be communicating perhaps with the patient, who has access to the information. Of course, the physician may need access to those records at a future date, and how she would have access and be able to obtain them as necessary. Those would all be likely negotiated through the service agreement.
Great. You want to move to the next scenario?
Yeah, I agree. Let's move on to the third scenario. What we have here is a patient coming into an ambulatory clinic, walking in. There are ancillary health professionals there at the clinic, and then the patient will have, during their visit, a video exam with a remote physician. It may be a dermatologist or a neurologist, a specialist of some sort that is not available on site at the clinic, and there would be a live real-time video exam through some application or video process. Could be anything from a Skype to a more EHR-based exam. So, Sharon, looking at this, scenario, how would you examine HIPAA and its application here?
Thank you, Rebecca. So, in this scenario, we actually have at least two covered entities, right? So we have the MinuteClinic or the walk-in clinic, and then we have the patient's physician or specialist that is receiving PHI on the other end. And this is all, protected health information, but query who owns that record and who is responsible for administrative, physical, and technical security, who issues the notice of privacy practices, who stores that record after the encounter, who is really taking ownership of that PHI, right? So that's really, I think, a difference here than in some of your other scenarios. And I think as data indicated early on, this is what we would call a simultaneous telemedicine transaction, right? Unlike the radiologist where, in Rebecca's example, it was late at night and it wasn't real time. It was, later that was actually read by the radiologist. One of the very interesting things that, from a regulatory perspective, we have to consider is that video examination in the middle. Obviously, where is that video exam taking place? Making sure it's in a physical, private space. Again, who owns that record in terms of the video exam? Who's going to store it in the medical record for future use with another service provider? And how secure is that video transmission to begin with, right? If it's Skype, there's a ton of network connections that are in play here that, can be accessed by the bad guys. There are, extra business associate agreements. Who's in that room taking the video exam? Is that an employee of the, covered entity, or is that a service provider that is, a videographer? And if so, then we need those business associate agreements in place to provide that chain of trust, if you will, as it flows through that PHI from the walk-in clinic through to the treating physician.
And do you see, in terms of how the relationship with the patient works, do you see some areas of concern of how to address those?
Well, the relationship with the patient, I think, is one of the more interesting aspects of this scenario. If it's truly a MinuteClinic or a walk-in clinic, is that, being a treating physician, as we would think of that under HIPAA, or is that just a service provider, right? That then making sure that the video exam is in the hands of the physician who is treating, would indicate that physician has a little bit more preference and relationship with the patient. One of the things that's very interesting generally in telemedicine is, we're sending messages about people's medical conditions back and forth, and, they're being intercepted by medical providers, but are those medical providers really treating, or are they some sort of consulting relationship along the way? And, this is really much more of a telehealth encounter than it is a treating encounter. So those are all sort of thought process questions. We also have to consider state law. We also have to consider if it's really much more consumer-driven healthcare, that we have privacy policies in place that describe how information is collected, transmitted, stored, and who sees it as part of this whole stream of data, medical data flowing. And finally, just let me say that one of the other analyses, especially here, is it could be data collected by the patient, and then that is regulated by the consumer regulations, but when it's transmitted to the medical chart with the treating physician, it becomes HIPAA-protected data, and then it goes from HIPAA-protected data back to consumer data. So those are the challenges from a regulatory perspective.
This is Brian again. That third CLE word I wanted to give before we go into the last 10 minutes here is going to be pepper. That's pepper. So the first word was data, second was safety, and the third is pepper. Thanks.
So at this point, Brian, I think we probably need to move to our best practices from a closing perspective given time. I'd like to take the first few, and then Dana will wrap up with the additional best practices. So preparing for the relationship of telemedicine. I think the scenarios indicated that, it's just a little bit different than your normal acute encounter, and you have to respect that, right? And the process is kind of different whether you're a covered entity or whether you're a business associate. From a credentialing perspective of healthcare providers, the question becomes, is this just, one encounter that a provider decided to do from a telemedicine or virtual perspective, or is really this now the course of doing business by that healthcare provider, which then would lead to more licensing and credentialing issues? As we mentioned in the last scenario, there is a telemedicine session. There are service providers and videographers and people like, monitoring your Skype connection and, from an IT perspective, helping you do these virtual sessions. Are they, protected with a business associate agreement or some other sort of agreement that respects that individual's medical information and patient privacy? What is the scope of those telemedicine encounters? What happens to those records? And then you need to have very robust consent forms that may be enterprise-wide consent beyond one healthcare institution to a diverse healthcare institution and data sharing records. Medical record documentation requirements we indicated, as well as clinical guidelines, so that everyone's on the same page in the continuum of care. And even though they may not be in the same room, they understand the goal in treating that patient. There's a lot of equipment involved. You leave your cell phone, your iPad, somewhere that's unsafe. The network connections in your laptop are unsafe. I can just indicate, because I lead our data breach response team, that from laptops are probably the primary source of data breach incidents. And in robberies, 1 out of 3 robberies involve the theft of some sort of device, cell phone, laptop, mobile device. You need to anticipate that and plan for that. Updating and revising policies and procedures. The FTC is very cognizant of what you say to patients and consumers about how you're caring for that medical information, and you have to comply with those procedures that you outlined, or you might be subject to unfair, deceptive, misleading, fraudulent trade practices. Doing risk assessments, inventorying your data of your current operations and future operations. And HHS has put on its website a full risk assessment that's downloadable to an iPad that you can do for your institution for free. Next slide. Also, in preparing for the relationship, you're going to need robust policies and procedures for privacy and security, breach notification requirements, as Rebecca indicated, and transparency and notice of consent from an FTC perspective, as well as state-specific rules, such as the time that is required to provide that breach notification to end-user consumers. From a security perspective, I would recommend that you look at the FTC's most recent report called Start with Security that has 10 easily executable steps to security management. It's very well done, and if you would like a link to it, please let us know and email us. Looking at business associate agreements and sub-business associate agreements with service providers, have those in hand. Make sure you're training people. Make sure you're not just leaving all those policies, procedures, and business associate agreements on the shelf, but rather enforcing and monitoring the exchange of data across that telemedicine highway. Dana?
Thank you, Sharon. Next slide, please. Once you've prepared for the relationship and got all of your documents in order and you've thought through what this is going to look like, you are going to need to enter into a number of agreements with your various the other people involved in the arrangement. We've already talked quite a bit about the provider services agreement between healthcare providers and the business associate agreement, which is the standard document that governs the relationship between a healthcare provider or another covered entity and some type of vendor. There are other vendor agreements that would be important to think through in the relationship and make sure that you're crafting them with an eye toward privacy and security. That would include a management services agreement for any type of organization that is providing backroom type work, claims processing and things of that nature, HR. They may have access to PHI and need that for their services, and so that would also be something that you'd need to think about, as well as equipment agreement and then technology and software licensing agreement, thinking through who's going to own the equipment. Are you going to be leasing it or buying it that you might be using, and who's going to be maintaining it to ensure that it's working in proper order, and also with the technology and software licensing agreement, will those vendors have access to PHI or not? If you're on a website, you also will need a terms of use and a privacy policy. That the privacy policy likely would be different than your notice of privacy practices. So those are other documents that you'd need to be thinking through from a privacy and security standpoint. Next slide. Just delving a little bit more into the business associate issues, make sure that you've identified when you're setting up the relationship that you know who your business associates are and that you've really worked through all of the negotiable issues. Will you allow your business associate to de-identify data? Will they provide data aggregation services? If there's a breach, who will be responsible for the notification? Those are the types of things you'll need to negotiate. Cybersecurity insurance is another negotiable item that you'll need to think through very carefully. And you also want to work with your business associates to make sure you understand how the data will be flowing. You may ask your business associate to provide a data map diagram and provide their own risk assessment that they've conducted so that you understand what they're doing with regard to privacy and security. And think about how you're going to move forward in the future if the relationship falls apart, what will happen to the data, and think that through ahead of time and negotiate it and include it in your agreements. Next slide. So once you've set up your terrific policies and procedures, you've got your agreements with all of your vendors, you know where your data is and what you need to do with it, you need to manage the relationship, and you can't just sit back and say, great, we're good, push a button and go. You need to do periodic assessments and audits to make sure that the process is working the way that you expect it to and the way that you planned for it to. If a breach occurs, you need to handle breach notification in line with the policies that have already been written. your vendor needs to make sure if the breach is on their end, needs to make sure that they are getting the information to you and then participating in the breach. And to the extent that as you go forward, there are new technologies, new data, the relationship likely will expand. New services will be offered. You need to make sure that when you're adding those new services and those new modalities for providing care, that you're thinking through all of the things that we've just discussed, and you're not just tacking things on, oh, this is, we've already got a compliant program, let's tack on this new service, without really thinking about it. Also, you should be updating your policies and procedures as you go forward as things change, because it's often the case that policies and procedures are written and then the actual practice is different, and your two choices are to change your practice or to revise your policies, and that's something to consider. And you should be doing ongoing communication and training with your staff and making sure that the staff of any relationship partners are also being trained appropriately. Next slide. Just briefly, if there's a situation where a relationship is terminating, either because it's expired or because for some reason there's been a problem and the parties need to walk away, you need to really think carefully about making sure that the data is protected, that the healthcare professionals will have access to the data in the future if they need it, and that the business associate who is not entitled to maintain the data is destroying it or returning it as necessary. And that gives us, that's the end of the presentation. That gives us 1 minute for questions. I don't know if we have any questions. Brian?
Yeah, before we have about 2 questions, but before we get to that, let me just give that last CLE word for folks. It's going to be medical. So it's data, safety, pepper, and medical for those that are looking for CLE. And then we do have a couple questions, like I said, so we can kind of take them right now. So here we go. I'll just throw it out there. Is a patient-provider telemedicine services documented through a provider agreement or service agreement?
Could you repeat that?
Are patient/provider telemedicine services documented through a provider agreement or service agreement?
I think we were using those terms interchangeably. Generally, the agreement, the point we were making is that if you have 2 healthcare providers or covered entities, a health plan and a provider, something like that, that you would have a professional services or a provider services agreement, or we might call it a services agreement between those entities in lieu of a business associate agreement, which would be the document you would use between a covered entity and a non-covered entity.
And is a video exam with the provider in office and patient at home documented in provider or service agreement?
Well, the agreement needs to delineate the roles and responsibilities and obligations for administrative, technical, and physical security, and who's really going to own that encounter. How you do that, whether it's in the provider agreement, the services agreement, or even theoretically in the business associate agreement, it just has to happen. So I don't know that we are strict about the title of the agreement as opposed to the substance of what needs to be done so that the encounter is properly documented and cared for securely in the medical record.
Okay, that's the end of the questions that we have right now, and we are a little bit over the hour. So if everyone's okay with that, I think we'll finish for today. We are going to put this webinar recording on Pepper's website later this afternoon, and if you are interested in the CLE, my email address is on the screen right now, and you can email me, and I'll send you the form offline, and we can square you away with that. With that, I'd really like to thank everyone that participated, both as attendee and the presenters. It was great, and we'll cut it short there. And if we have a future webinar in this space, we'll make sure to send an invitation to everyone. Thank you.
Thank you.
Thank you.